So why didn't a menopausal woman go to the park?
I don't know. Why?
She had enough mood swings at home. Oh,
that's bad.
That's a bad joke. I know.
This is Stirrups, Candid Conversations in Women's Health, the podcast where we answer your burning questions and discuss the evolution of women's health through every stage of life. Join Dr. Randolph Scott and duly certified women's health nurse practitioner and certified nurse midwife, Kerry Autry, as they discuss the unique health concerns women face and share expert advice to assist you on your journey to maintaining your health and wellness. If you're looking for informative discussions, tips from qualified professionals, and a community dedicated to women's well-being, then you're in the right place.
Couldn't find anything better. You know, I am not a creative soul, but we're going to roll with that, okay? It's a start.
To be fair, there is no safe menopause joke. Like, I don't think there's anything that you could
I think
say.
I was towing the line right
I
there.
know. Well, I don't know. I don't know if you had any good choices.
Okay, all right. So we'll move on. That I stuck my foot in my mouth here. So moving on, menopause.
But you feel like many partners out there who are it's hard to talk about. It's hard to talk about with your partner and not have them feel defensive because they're like, I have no idea what's going on either.
I know. And that's why I'm going to take a defenseless position and I'm just going to sit here and I'm going to listen to you, Kerry, talk all about menopause. And I'm just going to agree with everything that you say. That's what we're going to do.
I can tell you've been married for a long time.
Yeah, that's right. I'm going to stay married a long time.
That's right.
Just keep my mouth shut. Okay.
It's like you sound like my husband. All right. So what we're talking about today is we're talking about menopause because we talked a little bit about perimenopause in the past. And today we're going to talk a little bit more about menopause. But I think we're going to spend most of our time today really talking about the management of menopause and what does that look like for different people. Yeah. Because I think that our office is not unusual in that we have many, many people calling us every week asking for help. And I think that, you know, the generation of women who came before us just kind of like silently suffered. And our generation, my generation, I'll claim it. We're just like, heck no.
No, you guys are empowered.
I'm not going to sit home and feel this awful. Yeah. And I think there's been such a movement lately, you know, talking about menopause and what women are experiencing and, you know, sort of the new thinking is that they just don't have to sit back and accept this. You know, I read recently somewhere that the ovaries are the only organ that we're just accepting at some point they'll just fail and they'll just stop doing their job. And that's okay. That's okay. There's no other organ that we're like, that's not a problem. But the ovaries are like, they just stop working. And
that sounds like a good read. I need to go back and check that out.
So they call us for that first visit, Dr. Scott. And what would you want them to bring with them for that first visit? Because we're going to ask a lot of questions.
Medical history is important for us to really tailor a plan that is specific for you. Mm-hmm. There are so many ways that you can address the problems of menopause. And so your personal history, your family history, is very important to help making some decisions that would be appropriate for you. And so that's where the conversation really should start. Your family history and your personal history before you ever, get out, this is the symptoms that I'm having. Now, this is, of course, for new patients who are kind of entering into a conversation. Your more established patients, you have all that history kind of in front of you, or perhaps maybe some things may have changed in the family and so forth. But that's where the conversation begins, is with your personal history and then following the symptoms that you may have.
Absolutely. I mean, we want to know a lot of things. We don't know what kind of medications you are on, but I think one of the things that we want to be really careful as providers is not dismissing things that are physiologically wrong as menopause. Yeah. I want to make sure your thyroid's still working well. Are you anemic? Are you exhausted all the time because you have no red blood cells that are capable of doing the job? So there's a lot that goes into it. And, I want to know the medications that you're taking. If I have a patient who's complaining about low libido, is it menopause? Is it a relationship concern? Or is she on a really high dose of SSRIs and the medication is actually causing that symptom? So we have a lot of questions before we ever get to the things you're experiencing.
Yeah. And not only from a symptom standpoint, I think it's also important for us to get laboratory testing to rule out anything else that could be contributing to your symptoms. But for any patient that I'm really even considering starting on medication, for the most part, I make sure that the patients are up to date with their annual examination, that they've had some level of mammography or a mammogram. And generally also will recommend, especially if I'm going to use some form of estrogen, is to get an ultrasound as a baseline, particularly if you haven't had one in quite some time. So I think not only blood testing, but some additional testing can be helpful too. And Kerry, so what are some of the things that you also screen for when you are doing at least your evaluation and workup?
So I'm usually asking a lot of questions. I'll do, blood work to check your liver, your kidneys, make sure your thyroid's working well. I want to know anything that may indicate that you have an elevated cardiovascular risk. But I agree with you as well. I want to see that your mammogram is up to date. I'd like to see that your pap smear is up to date. And I really want to understand if you're having any bleeding, what that looks like. Because you're right. Like, we want to make sure that we're not causing more trouble than we're fixing.
Right. And sometimes it's really hard to know whether things are menopausal in terms of the symptoms that the patients are experiencing, or is this just a bad moment and bad time in their life? And so sometimes I'm actually screening patients for depression about some of the symptoms that they may be experiencing and some of the personal issues that they have in their life, and how can we help manage that?
Well, and it often all goes together, right?
Yeah.
Like, it's all existing in one person. And sometimes it's like, I tell people all the time, it's like a chicken and the egg question. Which came first? You feel terrible or the depression?
Yeah.
Or, I mean, it's so hard to tell. So we really need to be managing all of those things. So when, I think just because of history and culture and all that, sometimes when we're asking questions about depression, when you came in to talk about menopause, it may feel dismissive, but it's not. It's really just part of the whole conversation. Because if we're really caring for the whole person, that depression plays into it. Right. And the other thing I see often that's new that people don't expect is anxiety. And they have this new onset anxiety, and that often is hormones. But sometimes, it's that you're working too much. Sometimes it's, but those things, again, they don't exist in a vacuum. Like, those are all part of it. So,
yeah, there's no good way to describe menopause, but it's, for what a lot of patients will describe to me, it's like all eyes on me, where you feel like people are staring at you. You're flashing, you're on fire, and you got a tank top on, and you're flushed in the face, and it's hard to string, some sentences together. And so patients are feeling very self-conscious about where they are. And you're right. So all of that is intermingled, and you want to try to sift out some things that you would manage in a different kind of way, depending on how the patient responds to some of the...
Or in addition to
some of the symptoms that they have.
I think it's really hard. I think particular, just the way that we manage medicine in this country, it makes it really hard, right? Because we've divided people into boxes, and officially as OBGYNs, we care for like 3 organs, right? But hormones, they act all over the body. They don't like to act in the same way that we like to care for people. So it makes it really, really challenging, because we have these hormones, which are officially female hormones. So we're supposed to be taking care of it, but it has an effect on your heart and on your brain and all these other things that, as a rule, we don't really like to deal with, because that's not really where our strengths lie, let's say.
That's right. And you're right. So sometimes it is a community experience where you will have your cardiologist involved. Sometimes you'll have your surgeons involved, particularly breast surgeons and things of that nature. So you're right. It's a community. We don't profess to have all the answers, but at the same time, we want to try to help you get through the particular experience that you're going through. And so I think...
And we will sometimes ask for you to sign off with other doctors. You know,
Right.
if you're being seen by a cardiologist and you're interested in starting a medication and there's a risk to your heart,
Right.
I may ask you to say, you know what, just check in with them.
Yeah.
Let them ask them if it's okay. Have them send me a note saying that they're okay with it. And it feels like an extra layer, and it can feel really challenging for patients. We'll help navigate that as much as we can. But at the end of the day, I want to make sure that you feel better, but we keep you safe.
Yeah. Safety is utmost important. And so that leads us to really management. And there was a big study in the early 2000s, and it really changed how we really manage menopausal symptoms. As a matter of fact, years ago, the number one prescribed drug in America was estrogen.
Premarin.
Yeah, it was. It was no doubt about it. And then,
And if you have you ever seen the advertisements for it?
I do not remember the advertisements
Oh,
for it. No,
man. So it was like the number one prescribed drug in the 70s, but the advertisements were all to the husbands. Get your wife on Premarin because your life will be so much better. It's honestly like fascinating if you look at it.
That's a history lesson right there.
Say.
Yeah, exactly. That's a history lesson right there.
Yeah.
So everything changed. So what was it?
So the Women's Health Initiative, 2002, they had done a really far-reaching study on the effects of estrogen specifically in women. And they had been going along, and then all of a sudden they announced an end to the study overnight. They came out and they had this press conference and said, estrogen is dangerous. It causes heart attacks. It causes strokes. Nobody should be on estrogen. End of study. And they stopped the study. Yeah. And I was not working in OBGYN at the time, thank goodness, because I cannot imagine what the phone calls were like that next day. It must have been terrible. But the bottom line is we took everybody off of hormones, and really it was rare to prescribe hormones after that study was stopped. But once we started to actually dig into the data, what we found is that the risk was not universal. The risk is actually really specific to different populations. So there are some people who really truly cannot have hormone replacement therapy, but there's actually a really large number of people who can safely have hormone replacement therapy. But it's definitely a discussion that you need to have with a provider and need to hear them if they're telling you it's not safe for whatever reason. But generally speaking, those risks are increased if you have been menopausal for more than 10 years. So if you have not had estrogen in your body in 10 years, us putting it back is more dangerous. So at that point, really, the risks outweigh the benefits. So we tend not to start people on hormone replacement therapy after that. And then anybody who has a significant cardiovascular risk, we tend to be much more cautious with estrogen because it's sort of a double-edged sword, right? It does a lot of good things for us, but it does also raise that risk of stroke.
And so safety is the primary importance to help managing some of these symptoms for some of the things that you have said. And so we try to provide patients with different alternatives and things that you can take besides just estrogen. But I think it's certainly important for us to kind of go over some of the non-hormonal as well as the hormonal treatments. And
we will, absolutely. Both. So why don't we, do we want to talk first about some of the non-hormonal choices? Or you want to dig into hormones first?
I think the best circumstance is to talk about really the hormones, because that's the primary way that you're going to treat really some of the menopausal symptoms that you have.
Yeah.
And for most patients, I think there's really two lines of treatment for you. So you're either treating something above the neck, meaning the hot flashes that you can experience, or below the belt. And sometimes it comes in vaginal dryness, irritation, even pain with intercourse can be a factor. And we try to get really focused on both of those. But again, there's both hormonal and non-hormonal. But I think the hormonal aspect is the number one way to help manage some of these symptoms. And we'll have you touch on that a bit for us, Kerry.
Yeah. So hormone replacement therapy, and that's really what we call it once we're starting to talk about perimenopause, menopause. It is a very broad category, and there's a number of different agents that we use in that category, and there's a number of different ways to do it. Sometimes that looks like putting people on birth control. And often that's what we do for people who are perimenopausal, so still having periods, because it really just makes the bleeding neater. But sometimes I'm putting somebody on birth control and they feel great for 3 weeks out of the month. And then that 1 week where they're having their placebo pills and they're supposed to be having their periods, they feel really awful. And for those patients, I'm usually kind of making adjustments based on that.
Yeah.
Hormone replacement therapy is so individualized. It's really hard to make broad statements about it. I'm like trying to make broad statements. I'm realizing, wow, but yeah, I changed that for her because it is so individualized. So one of the biggest things that you need to know about hormone replacement therapy is if you're going to be starting that with a provider, you're probably going to be touching base with them pretty often at first as we make really kind of minute changes to your therapy, really based on what you're experiencing, symptom control, any side effects that you're having. But when we're talking about, for most people who are on HRT, I'm usually using a couple of different things. I always am really kind of preferencing an estradiol patch. So I'm usually putting people on an estrogen patch because that has a little bit lower risk profile than oral estrogen. And then if you have a uterus, we have to put you on progesterone. But I feel like progesterone gets such a bad rap.
Yeah,
it's so good for so many things on its own, and people are just getting put on it because they have to have it.
Right.
But so for me, when I'm starting people, you have that estrogen patch, and I usually have them take progesterone at night as a capsule because nothing is going to help with the sleep or the night sweats better than progesterone.
Yeah. Progesterone alone can be used to
I use progesterone alone all the time.
Yeah, it can help manage some of these symptoms. And so you're right. So if you have a uterus, you must be on combination therapy.
Yep.
You must be on both estrogen and a progesterone. The estrogen is stimulatory. It's stimulatory at the level of the uterus, but it's also stimulatory at the level of the breast. And that's why having screening mammograms is also important for patients.
Absolutely.
The progesterone, or the P, is protective. It's protective at the level of the uterus. And so for patients who are taking hormone replacement therapy and they still have their uterus, it always should be a combination, either estrogen and progesterone. Now, again, we talked about treating some of the menopausal symptoms with progesterone alone, but usually the best form of medication for patients is a combination of both of them.
Yeah.
And so now we get to other forms of treatment, whether it comes from
hormones, or I was like, where are you going?
Yeah. And so we're going to the bioidentical aspect of things, plants, animals.
There's a big movement out there that some people think they have to have bioidentical. And there's a lot of confusion about what that means and what is the difference between bioidentical and the more traditional forms. The research is really it does not support a significant improvement with bioidentical. Some people have a preference for that. And if that's your preference, then certainly that should be honored. But there is not a lot of research saying that you have to have the bioidentical over anything else. I will say that I prescribe far more of the traditional because as a rule, the insurance company will pay for it, which is not a small thing.
Right.
The bioidentical prometrium, as opposed to the micronized progesterone, which is the more conventional version, although I actually like micronized progesterone better for a lot of reasons. But the prometrium is significantly more expensive. I mean, you can be looking at, especially if we're using it daily, as I do later, hundreds of dollars out of pocket each month.
Yeah. So I think we practice in a very similar manner, that we don't just practice in a way that we just hand out patients medication, but we also think about the cost of what that would mean for the patient at the same time. So there's a financial burden that comes along with it, and
with the bioidentical,
and so,
also I even have a little bit of a concern about it. I'm not sure that the progesterone, the bioidentical progesterone, is as protective as the micronized, and the studies are showing that micronized is better for the breast risk.
Right, and so that's what I tend to prescribe for most of the patients.
If they feel strongly, we'll have a talk about it, and we'll certainly look at it. But I think there's also a lot of fear out there that a lot of these hormones are still containing animal products, and most of them don't. Most of the things that we're prescribing at this point are synthetic.
Right.
So it's really just a question of if it's plant-based or if it's synthetic. But even the plant-based bioidentical, by the time they've made it through the lab, I'm not really sure how much plant-based is left. But those two things do exist, and it's worth a conversation. If it's something that's very important to you, for sure, you should discuss that with your provider.
It really has come to mean so much for a lot of people in terms of what the definition is. But at the end of the day, patients have a certain level of expectation about what their hormone levels are and how those hormone levels are adjusted based upon what their particular levels are. And so some providers are getting a hormone panel and then making adjustments based upon the hormone panel that they do so that it's tailored specific to the patient. And so that's where it becomes a bioidentical kind of circumstance for patients, where they're getting some tailoring to their specific hormone needs and making adjustments based upon that. So that's where it kind of comes in. So it's been popularized. A lot of providers do it, make adjustments that are specific to patients rather than just kind of starting the patients at a certain point and then managing based upon the symptoms that the patient would experience from there. So,
and it's that, the bioidentical, it's a pushback against two things. Their initially hormone replacement was primarily made from estrogen that was derived from urine from animals. Mm-hmm. Yep. And there was a big, that does have kind of an ick factor to it. So there was a kind of a push. Then they started making synthetic hormones. So there's hormones that come from animals. Then there were synthetic hormones, which is what the vast majority of conventional prescribed hormone is at this point. It's just synthetic. But then there was this sense that it would be safer because hormones come with risk. Somebody came up with the idea that it would be safer if it were plant-based, and it looked chemically like the same hormone that's in your body. So bioidentical initially came from plants as opposed to being from animal or being completely synthetic. But he's absolutely right in that that they kind of took the bioidentical a little bit further and then were compounding hormones that were really supposed to be tailored to a specific person and meet, specific goals, whether those goals were symptom management or tailoring to their particular lab values. And so there's this whole compounding pharmacy thing, which is a whole nother thing. And I do use them, so I'm not trying to dog them, but and in fact, I use them quite a bit. But there is some, there are definitely some providers out there that, have embraced the bioidentical, and there are some providers out there that are really anti-bioidentical. And you'll find a lot of people that will say things like the compounded hormones are not as reliable. They're not as consistent. And I don't know if I think that is true as much as you need to, I don't like using products that have several different hormones in them because it's hard to adjust them individually. Right. And if we're going to be using a compound, because there's some things that I do compound just because it's too hard to do it any other way, find one pharmacy and stick with that pharmacy so that it's consistent across your therapy. Does that make sense? Yeah. All right. Because like testosterone, I can't prescribe it over the counter. You've got to have it compounded because it's just too hard for women to use the products that you can get at the pharmacy because they're all dosed for men.
All right. So we're going to talk about the non-hormonal management side of things. We touched on management with estrogen and progesterone. But now the non-hormonal certainly can be addressed because not everybody can take hormones. And so the first line of therapy is actually what we call a SSRI, which is a serotonin selective reuptake inhibitor. And that is the primary way. That is also the way that we manage and actually treat depression. So Paroxetine is first-line medicine in terms of trying to manage some of your menopausal symptoms. without the aspect of hormones. Unlike depression, the management for vasomotor symptoms or hot flashes is often a lot more rapid response. And so patients will see a benefit a lot earlier. When you use paroxetine for depression, you may not see a good result for 6 weeks. But if you use it for hot flashes, it may be several weeks before things actually will be more helpful for you and to see whether or not if you'll find a difference. When I use it, that's where that medical history becomes important because patients with breast cancer, I tend not to use paroxetine with patients with a history of breast cancer because there's some suggestion that the SSRIs may not allow tamoxifen, which is really a risk-reducing agent that you use in breast cancer, that tamoxifen doesn't work as well in combination with the paroxetine.
Now, do you feel comfortable? I will often put patients on it after they've finished the tamoxifen.
Oh, yeah.
Do you, because it's usually a limited amount of time that we have a breast cancer patient on that.
That's correct. And so
thank the Lord for that, because it's tough medication.
It's a dreadful medication to be on in a lot of respects. But as a matter of fact, the tamoxifen can contribute to more of your hot flashes, right? And so that breast cancer patient or breast cancer survivor is certainly an important
vaginal dryness. Oh.
Yeah, that's another problem that medication will cause.
Yep.
In addition to the symptoms that you already have. And so for patients who are on tamoxifen, we also consider some alternatives. But this is where we talked about, again, having a really approach from multiple providers being involved in your care. Because some patients will use medications like aromatase inhibitors like letrozole as opposed to tamoxifen to help manage their breast cancer issues and concerns. Now, there has been no issue with paroxetine and letrozole. And so you can use that as an alternative, particularly if there's some issue of breast cancer in the past. And so that's a special kind of situation from a non-hormonal use. Paroxetine is one of the few that has FDA approval to treat hot flashes for patients. And so this is something that's been well studied.
Do you ever prescribe that though? So I prescribe paroxetine, but the special product that they came up for menopause hot flashes in that 7.5 milligram dose, it's like 3 times as expensive as just generic 10 milligrams paroxetine.
I almost never prescribe it as a brand name. So that's why I'm not even using the name.
More expensive.
I'm not using the name because the brand name, I don't even want to use it.
I'm like, we'll just put you in 10 milligrams of plain old paroxetine.
And so you're right. Very rarely do we prescribe it as a branded name, but paroxetine as a generic is certainly appropriate for you. Now, the one thing about that particular medication is that it has to be tapered if you're going to consider coming off of that medicine. We don't recommend for patients, for cold turkey aspect and in terms of using an SSRI to help manage some of your menopausal symptoms. There's also anti-epileptics. And so patients with seizures will take a medication called gabapentin. Gabapentin has been shown to be useful for a variety of things, but particularly for hot flashes, it can be helpful.
It can help with the sleep. I mean, actually, it really is. It's a good tool, honestly. It does a lot of things for us.
Yeah, it provides a lot of relief for a lot of symptoms. We often use it with patients who have painful diabetic neuropathy. So you'll see it in a variety of ways and variety of patients taking it for different reasons. But what I don't necessarily do is combine the SSRI and the gabapentin together because
it's one or the other.
Yeah, it's one or the other. So we find that that's beneficial for patients, one or the other, but not necessarily both. There is another medicine called clonidine that I very rarely prescribe for patients. It can be helpful to manage the hot flashes, but sometimes the side effects are not necessarily pleasant where the patients are having dry mouth, dizziness, constipation. We fixed your
hot flashes.
Yeah, but this is what we got to do. So you'd just rather deal with the hot flashes than deal with all that. So you're right. There's another medicine that we often use, and really is to help patients with an overactive bladder. And that medication is called oxybutynin. That has been shown to be helpful for patients, really above the placebo effect of some other medicines that you can use to be helpful. And there's a newer medication that's on the market now that I've been prescribing.
They were advertising during the Super Bowl.
Oh, the Super Bowl again.
They had advertisements during the Super Bowl. I was like, we've made it.
Okay. We have arrived?
We've arrived. Like, we're getting advertisement during the Super Bowl. But go ahead. What's it called?
Now, this time, since it made it to the Super Bowl,
you don't even need to say it, but go ahead.
I can use the brand name, okay, as Veoza, okay? The generic name is hard for me to actually say, so I go back to...
I don't think anybody calls it that, yeah.
And this particular drug, for some reason, when I see it, I think of New Kids on the Block. I know I'm not going there, but hear me out from my explanation, okay? All right. So I grew up with New Kids. Did you grow up with New Kids? Did you go? Okay. All right. The right stuff, right? Okay.
Exactly.
This is the right
Takes
stuff.
us back to Madonna yesterday. Man,
I'm sorry. You know what? I'm putting too much of a plug for this medicine, but no, it's actually a great medicine. But the way that it works is what's called an NKB antagonist.
Is that how you got
there?
There
you go. That's how I went there. You see, NKB antagonist. And, just for, the purposes of knowledge, that stands for a neurokinin receptor antagonist. And so that has been shown to be very helpful.
I dare you to go into your provider and ask for.
Better ask for Veoza.
Yeah. It is a good drug, but it is one that we have to get some labs before we start and get labs a few times after we started, just to make sure, again, that we're keeping you healthy and not creating new problems. Right. But it can be very, very effective for the hot flashes.
Okay. And then we talked about the use of progesterone alone. That can be helpful to manage some of these lingering symptoms of hot flashes. And then there are other therapies that we didn't touch on, Kerry. Some of these plant-based therapies. Do you find yourself using much of those?
Only every day.
All right. Well, what's your favorite?
I tell people all the time, I'm like, I'm not a doctor. I'm a midwife and I'm a nurse practitioner. So I do a lot of things. I do some herbs. I do some supplements. I do prescriptions that are hormones, prescriptions that aren't hormones. Okay. We will find your path. I don't know what it is, but we will find it. Right. I see you've got some black cohosh here. I do
there
use
you go.
That.
Okay.
And what's funny, and I don't know why this is, but black cohosh is the go-to in Europe. When we're talking about herbal therapies in Europe, their go-to is black cohosh. In the U.S. and Canada, for whatever reason, it's Vitex. They're very similar. They're both plants. They look to our bodies like estrogen. So it's like putting estrogen in your body without any of the risks of actual estrogen, because this really is just a plant. Yeah. But both of them can be really, really helpful.
And so there's some options there. And then we fall into things that are more anecdotal, that are helpful for some patients, but not helpful for all patients. Things like acupuncture. It certainly can be reasonable to get acupuncture for the prospects of your hot flashes, but it may not be truly effective. Flaxseed is one thing there that's not necessarily been known to be more effective than placebo.
But really great for your fiber intake.
It may have some other problems.
Yeah, I mean, it's got some really good omega-3s. It's still take the flaxseed, but it might not stop the hot flashes. I really like flaxseed.
That's right. We're trying to manage expectations here, right?
But if you're somebody out there, just as a complete aside, as random piece of information. So for women, a decent amount of flaxseed is really good. For men, you can actually have too much flaxseed. In fact, about a tablespoon a day ground up is really good for women, but a tablespoon is really too much for a man and can actually increase the risk for prostate cancer. So only give your partner about half of what you're taking.
All right. Note to self, stay away from the flaxseed. I got you.
Well, no, it's good for the heart. Just less. Less is good.
All right. And so we are going to end this segment here. We have so much more to talk about
I know, I didn't even get to the DHEA and the testosterone.
No, we didn't. I mean, I call it
thyroid hormones so much.
Yeah, I call it below the belt therapy. So we will certainly touch up on that. Like you say, the DHEA. There's actually laser microablative therapy that you can use. There are vaginal moisturizers, but you'll have to wait for the next podcast.
Or come in and see us.
Yes, exactly.
Thank you for joining us on this episode of Stirrups. Be sure to send us your women's health questions and topics you'd like to cover by visiting our website, CarolinaEliteWomen.com. If you enjoyed today's episode, please subscribe to the podcast and spread the word by sharing it. To find out more information about Carolina Elite Women's Care, visit CarolinaEliteWomen.com. This podcast is edited and produced by Earfluence. Stay healthy and stay empowered. We'll talk to you soon on Stirrups.